Okay, welcome everyone. Thank you all so much for being here today. I'm Jamie Katz. I'm with Johnson County Mental Health Center, and myself, along with Barbara Mitchell with Johnson County Department of Health and Environment, are co-hosting this amazing presentation with Dr. Willey. And just a little background about Dr. Willey, just for those of you that don't know of him. He's incredible, but Dr. David Willey is the unit director of the Substance Use Disorders Unit at Cottonwood Springs Behavioral Health Hospital in Olathe, Kansas. He's a graduate of the University of Kansas Medical Center, where he completed his general psychiatry training and fellowship specializing in addiction psychiatry. He is board certified by the American Board of Psychiatry and Neurology in both general psychiatry and addiction psychiatry. And Dr. Willey has received numerous honors that include the Sean M. Memorial Award, Chief Resident of Psychiatry, Student Voice Award for Excellence in Teaching, and an Outstanding Academic Achievement Award. He has worked in various institutions around the Kansas City area and is involved with numerous organizations in the efforts to address substance use related issues in the state of Kansas. So, Dr. Willey, thank you so much for being here. Thank you for agreeing to become virtual. And and thank you all, everybody who registered and came today. So thank you all so much for being here as well. With that, I'm gonna turn it over to Dr. Willey. I will say the one thing just to note, you can put questions, anything in the chat. I will be monitoring the chat, and we're going to try to make this as engaging as possible on Zoom. So with that, Dr. Willey, go for it.
Thank you, Jamie. Welcome everybody. I appreciate you joining us. Yeah, Jamie and I were chatting before this. We wanted to go live in person. Those of you who know me, you know, I am kind of a talker, hands guy, engage with the audience. These virtuals have been a little more difficult since COVID started for me. They're a little dry just sitting there watching people read slides. So you know what, it'll work though. So, but we were talking, if anybody has questions during this, because I know how hard it is to sit through presentations and just listen to someone talk about slides. I throw a lot of data up, but I usually just talk anecdotally about what's on there. The slides will be available through Jamie or whoever wants them afterwards. It's also being recorded. But if you do have questions as we go, because I kind of go all over the place and tell stories and talk about certain things. And as long as this is, if you have questions, you may miss at the end, it may be too long or down. If you have a question as we go through this, just ask and throw a chat out there and Jamie can interrupt and we can go from there. If not, we can wait till the end.
Depends on what it is.
Yes. Oh, sure. Okay. And then and then I will be available exactly after too. That I'm usually open, and I usually get a few people emailing me and getting in touch with me regarding management of patients, questions regarding MAT, the opiates and stuff, what's going on. Those of you, I appreciate you asking me to do this. I've done this a couple times. I have not done it as much lately. We just did a big presentation through Cottonwood Springs, where I'm employed, about 2 months ago. So some of you may have been there. We do a big CME event there, probably once a year for addiction accreditations for people. What I did is I put my slides, two of my presentations together here. So it's not specific just to opiates, but we'll talk about general things that we go through. We'll talk about the COVID, mental health, how it's affecting the opioid epidemic and substance use in general. And then the main topic we were talking about when we started was going to be MAT, medication assisted therapies too, which will be the final section that we'll go through. And I can give you my experiences and some education as we go. So I appreciate you all having me. I will probably take a break too, because we'll probably just go through. If anybody, obviously you can take breaks as you want, just so you don't have to hear me ramble for so long. But for those of you who haven't met me, my name is Dave Willey. I am an addiction psychiatrist. You must have got an old bio, Jamie, with all that stuff on there, because I've shortened it to like 3 sentences because it seems like a long time ago. But it's nice. It makes me miss my days in academics and teaching. That's one aspect I don't do enough of besides my NPs and my staff here. My personal story, some of you guys have heard. About a high affinity for KU. They gave me multiple chances. When I graduated there initially in 2000, I did anesthesia for 2 years. I got addicted to fentanyl while I was there, sent to treatment, went back, did not do well at all, had a tragic relapse there. They rightfully so said, hey, you should probably do a different field, which I didn't want to at the time, but they were right. So I left medicine for about 8 years, did business for a while, kept getting influenced by family, friends, people with substance problems. And many people encouraged me in 2010 to return to medicine. And KU was nice enough to give me that chance to come back and do addiction psychiatry for 5 years with the regular psychiatry fellowship, regular residency in the addiction. And then I finished in 2015. Those of you who don't know Cottonwood Springs, it opened the same time that I got done with residency, about in 2015. And we do psychiatric and substance use. And we have a unit here that is specific to substance use, detox, subacute rehab, and an intensive and partial hospitalization program. And we're talking about residential and growing as we go, especially with the state of things going on. I will say, it has been, we'll start here first with just kind of talking about, well, let me see how I get this, how do I do this screen here?
Just click.
Just click.
Mhm.
Oh, there. Okay, so some objectives we'll talk about. I don't want to just read slides, but I'm going to talk about some mental health as it pertains to substance use, because most of us are in just mental health and they're so intertwined these days. Developing a better understanding of how the COVID era influenced people. Have heard probably the overdose death rate's the highest it's ever been. Mental health is in a bad state. Preventative and treatment strategies to address not just opiates, we'll talk about alcohol and other things too, and to become better educated about the medication assisted treatments. Okay. Now, put this slide together, like mental health and substance use in the era of COVID. I think anybody, and I want to thank everybody in this room for your participation in whatever capacity you are in dealing with mental health and substance use or whatever your interest is, because it's not easy. And I think it's been extremely difficult for us over the past couple of years, especially amidst this COVID-19 pandemic and how it's influenced us. So these are some things I put together too, like, are we facing a crisis? And I'm not a doomsday guy, but it has been more difficult and I'm sure you guys have experienced that in your own practice. The newer data coming in, most people suffered an increase in anxiety, depression, and certainly in substance use. And then you couple that with the changes that happened during COVID with the way that we provide treatment or the lack of treatment because of our inability to see people in person or get care because of people closing their doors and limited options during COVID. It got pretty bad. But we did the best we can. I know that we here at Cottonwood tried to stay open and we managed to keep our doors open. I don't know if anybody here is an outpatient and inpatient. What's interesting about the COVID crisis is it's not going away, right? That's why largely why we're here virtual too, but it has not. We in our own hospital over the last 2.5 years, I would say we got lucky. We put the best preventative measures we could in place to screen for COVID, but for people in residential treatment, rehab programs, especially inpatient psychiatric facilities or in detox, besides nursing home, those are about the worst places possible for COVID, right? In terms of the spread of COVID and contamination and infection. So it became very, very difficult for us to manage when we had people with COVID or symptoms in isolation and had to close units for a period of time. Hospitals had to close. And interestingly, we got through that better than I anticipated. And we've had more COVID cases in the last 6 to 8 months with these new, more infectious strains that are going on with these new variants. And we're still trying to figure out how to navigate that. I don't know how you guys are navigating that in your own facilities, but it's difficult because the reality is COVID, for those who don't know, is not going away. COVID is here to stay, and the variants it's not something that can be eradicated. So we're going to have to deal with this COVID, and we're trying to figure out how to do that. Hospitals and a lot of facilities haven't really figured out how to do that from a liability standpoint. It's affected family engagement, families coming in. And people that can come into even the residential rehab facilities and in hospitals due to risk of contamination. But as it pertains to,
What do you mean?
Is there a question? No? Okay, sorry. But That's all right. Hey, interrupt anytime. But you can see like COVID, how does it affect mental health and substance? Quite a bit, right? Because if you take like some people refer to addiction as the opposite of social connectedness. So when you take people and you isolate them and they're not able to go to their meetings, they're not able to engage with their providers or their groups, they don't have their social groups. Of course, that isolation and boredom is one of the worst things. And we saw a massive increase in substance use, alcoholism, and mental health during that time. So, like a 30% increase based on one of these anxiety and depression. Now, here's something pertains to a lot of people in the room: essential and non-essential workers, right? Who was classified as which? Anybody in mental health and substance during the time? Yeah, I don't know about you. I'm not going to speak for you. I will tell you that my anxiety and mood symptoms certainly went through the roof, and had some difficult time working within the environment of COVID. It wasn't just patients, it was staffing. For anybody who tried to work through this, every day we have screenings with our staff. We have no idea who is going to have symptoms. If they have symptoms, they can't show up to work, they can't work, they can't engage with patients. So every day, even today, as we show up to work, we have staff that are on protocols every day, which makes it difficult. So for us in mental health and substance use, of course, we had, and you could see, had more of an increased anxiety and depression, and there was, there was arrangements, modifications, things made, including crisis pay for nursing, staffing, and all those type of things. I work at Osawatomie State Hospital as well on the weekends. And it's just been a difficult time for all of us that we're hopefully trying to get through. But again, this COVID, these variants are here to stay. Now, negative effect on emotional or mental health amongst people 18 and older, any mental health, yeah, 45%, serious 54%. Those are quite a bit or a lot. So now, why do I talk about the mental health? Because obviously there's such a huge correlation between mental health and substance. We know most, I would say, estimating about 2/3, if not more, of the substance use population have mental health issues, and probably about 20-30% of the mental health, maybe about 20% for what we see, have a substance use in our hospital based on the statistics. Now, what did COVID have an effect on mental health? Why? Like we talked about some of this for a little bit. Appointments moved to in person to telehealth, right? Now, there seems to be, I don't know if unintended is the right word, but there happens to be some benefits to the telehealth. I know that many people in community mental health at KU and other community mental health centers and other facilities, they have stuck with the telehealth model. And in fact, it has increased compliance for patient interactions and engagements and appointments quite a bit. On outpatients, the outpatient organizations that we work with seem to continue to do mental health or doing a hybrid. I'm seeing telehealth and doing a hybrid. I prefer in person. I like seeing the person in front of me and engaging with them. And obviously I'm an inpatient, is my specialty is on inpatient detox and engaging with the patients here. So I have to be in person. But a lot of people went to telehealth, delays and cancellations and appointments. I was understanding, but kind of shocked too. I was working with Dr. Doug Burgess over at Truman, who's a friend and a good colleague. The number of facilities that shut down during mental health was alarming for people not being able to get services during that time period, just because of people not being able to get to their doctors. Delays in getting prescriptions, we can imagine, not just for MAT per se, which are vital to say for opiates with Suboxone or withdrawal effects of multiple medications like benzodiazepines and other things, and just psychiatric medications in general, can cause huge issues in person's mental health and how they're doing, and unable to access care at all during that time period. Now it's improving, like I said. And during the problem, we talk about, we're kind of focusing on the opioid epidemic, but let's not forget about alcohol. Alcohol is still the most prominent issue in killing twice as many people a day as the opiates. It's just longer and slower. But it's still a huge problem, and it's still its own issue. Increase in alcohol consumption during the pandemic went up 31%, and increase in drug use went up almost 30% based on the mental health index. And here's interesting, people from home, I'm not speaking for anybody in here. I can tell you from personal colleagues and friends that I won't name, obviously, I can't tell you how many friends and family members came to me during the COVID pandemic with worried about their own alcohol consumption going up during that time period, when you isolate and people don't have to go to work and there's no accountability, and people who have that occasional drink during work or after work. 1 in 3 employees said it was were saying they were drinking more often during the day, especially during telemeetings and so forth. So I had many friends and family coming to me saying, look, I'm concerned, and it doesn't take long. If anybody's ever dealt with this, it only takes a matter of a few weeks of persistent and regular use before escalation happens, and it can start causing some significant issues. The substance use during the pandemic, they talked about, again, alcohol was the most common one, which makes sense. Alcohol in liquor stores were considered essential during the pandemic. They got pretty creative, and I'll show you some slides here on the alcohol. Like you can get alcohol delivered to your home during the pandemic, which went up 234% during the pandemic, and alcoholism went up as much as 30 to 60% during that time period. Prescription drug use went up. Recreational cannabis, we could spend an hour on cannabis if we wanted to, talking about the legalization, social aspects of cannabis, medicinal values, and so forth. That obviously is going up with the legalization, especially around our state, with Missouri, Oklahoma, and so forth, in Colorado, vaping, illicit drugs, and so forth. Now, again, this is kind of just reiterating what we were just talking about. Alcohol use disorder is still the most common, and I would say it's still probably, the last estimates are about 70–80% of people in substance use treatment, primarily alcohol. Now, Jamie and I were talking about this before we came in. At least 2/3 of the people who come into substance for treatment in this country, estimated, and I would say it's consistent here, are using at least 2 substances, and 1/3 are using at least 3 substances. And so if they use alcohol, they're using something to get up in the morning, or if they're using opiates, they're often using benzos or sedatives to sleep, or stimulants for the same thing, kind of self-medicating. Now, illicit drug use disorder, obviously that's what we're talking about with the fentanyl and the opiates. Marijuana use, obviously up, and pain reliever use. Now, this is where it gets kind of tricky, is because when we talk about fentanyl, fentanyl is still a prescribed pain medication. So how do you differentiate between what people are calling it illicit versus what is non-illicit and actually a prescription medication? Stimulant use, if anybody has paid attention or in this field, has seen a huge increase in stimulants over the past 2 years. There seems to be a correlation between opiates. It used to be cocaine and heroin, and now it's methamphetamine and fentanyl. It's kind of the new speedball and kind of combination that people are using. In the stimulants on the street that they have been testing, it's estimated more than 30% of the stimulants on the street have fentanyl in them, which is becoming more and more common, causing overdoses, unintentional, people not knowing what they're taking. And then heroin is still around, but it's not as prevalent with fentanyl coming in, and we'll talk about why that is. What's not on here, and Jamie and I were talking this beforehand, which is a scary phenomenon that's been going on for the past decade and really cranked up these past few years, is the synthetic derivative market. And what I mean by that is that people don't know what synthetic derivative market, research chemicals, or designer drugs, they're not tracked because a lot of times we don't know what they are, right? So there is in a huge market out there, $3 billion at least, what estimates on this illicit drug market, utilizing the millennials and the computer systems and the black ops and the webs. And now they've gotten so brazen that you can order many of these things online. And as the drug dealers are out there trying to avoid the legal system, they're designing new designer, more potent drugs that are not detectable or not known structures. So if they're not known, they're not illegal. And so you can have these substances delivered right to their door. And what we're finding that's even scarier in the new trends with the opioid epidemic is something called trank dope. And what they're mixing is with these designer synthetic derivatives of tranquilizers or more potent benzodiazepines called phenodiazepines that are mixing in, causing more increase in the overdoses. So there's a whole new market out there, and there's a bunch of stuff, to be honest with you, that I have to read up on, and I learn every week from my patients coming in and telling me what they're using, what they're buying. So that's not on here, but it's become more and more prominent, especially with the younger people. This is alcohol again. 70% of the people with the substance use or alcoholism. About 6.5 million have a mix of both alcohol and substance use, and 11 million with which is the substance use or illicit drug use in general. Now, this is based off of SAMHSA and something called the National Survey on Drug Use and Mental Health that's done every year. it's a really good kind of snapshot that they do every year that I track the data. It's a little different this year. We're kind of skewed because of the new DSM-5 criteria, but it still gives you a snapshot of trends. Again, this is we were just talking about, about a third of people actually are doing both substances, or at least two substances, if not more. This is what I was talking about. Sorry, my numbers were wrong. It was 243% increase in alcohol online sales, which I didn't even know they did, but apparently they do. And it makes sense of how people get creative in a capitalistic market. And so the alcohol is now just delivered right to your door during that pandemic. Illicit drug use. This is not a shock, right? Cannabis, right? Number one. I don't know. I would love to have conversations and be able to engage with you to ask all of you how you're dealing with the cannabis issue, because it is a prominent conversation, and I have at least once or twice, if not several times a day, given what I do in outpatient and here in the inpatient. People's perceptions of cannabis, the medicinal values. Many people come in and are not even quantifying or their use or even qualifying it as a substance problem. Like, people are just kind of glossing over it as, well, do you do any other substances? And they're like, well, I just smoke cannabis, but that's it, as if it's not an issue. And it's something that should be addressed. Another thing we should talk about that people don't talk about are the like the organics. Has anybody, people have heard of kratom? Kratom is a plant species out of Southeast Asia that's in the coffee family, an evergreen actually, that has opiate-like properties. And it is more times than is not uncommon, I should say, for me to have people in here for an alcohol problem or a substance problem, and they'll have these symptoms that we can't explain, that with the water eyes, runny nose, the aches and the chills, and how they're presenting. And I have to ask them, I'm like, this is not benzo withdrawal, this is not alcohol. I'm like, are you doing any other things? And it's amazing how many people don't even consider those things to be harmful or addictive at all. And I see a lot of kratom addiction in use right now, because people believe it's a plant-based product, that it's not addictive. So I have to treat it the same as an opiate and provide education. So make sure you ask them about supplements as well, because it's amazing how many people don't even qualify that or even cannabis as a substance. And with cannabis, like I said, I wouldn't talk a whole lot on cannabis, but cannabis these days, I'm kind of on both sides of this. I have to be conservative from an addiction side. I'm not one who's completely on one side of the fence that says there aren't medicinal values to organic compounds, especially medicinal cannabis. I see it used in therapeutic ways. In moderation, things are healthy. You do have to watch people's use, because there is an inverse relationship between substances. Take alcohol and marijuana. For instance, there's usually an inverse relationship between someone who comes in, which is very common. I have probably 4 or 5 in here right now who tell me, I'm not stopping it. I'm not going to stop smoking weed. Well, I pick my battles, and I just work with them on that and try to convince them to be abstinent for 30, 60 days just to see how they do. And see, but it's often when people try to quit one substance, they'll start using another, including those supplements, and cannabis is probably the most common one. Okay. All right. Well, I'm sorry, there were some jokes in here my colleagues put in, but that's not bad. So those who can't see, cannabis can be used for safe, effective pain management. All I can prescribe is a decade of opiate addiction and probably an early death. Well, that's a tongue-in-cheek at our own country of what for the first wave of the epidemic that I'll talk about a little bit. But past year, we're talking here to talk a lot about the opiate problem, because that's the most prominent and most deadly thing going on right now. But past year opiate use, this is again kind of skewed. If you look at pain reliever, it's 97.5 of users. Now, I would classify that as the fentanyl, right? If you can see, heroin's kind of become up 2.5%, which is a much smaller. So if you look at the population of what the trends are and what the overdose is, it's not necessarily a huge number proportional of new people doing opiates and new opiate addiction, even though it's more prominent in the younger people. It's people transitioning also to a more potent and more deadly opiate itself, being fentanyl. And that's taken on a whole life of itself, and the dangers of that, from heroin to fentanyl, causing much more overdoses. Now, this is kind of an interesting one that was because of, if you pay attention to the details, this is the breakdown in that same survey of prescription reliever misuse, like which substances, right? can anybody see on the right side of the past year what the most common is? Buprenorphine, right? Well, that's not necessarily a bad thing, right? Because we'd much rather have it be buprenorphine, which people who don't know what buprenorphine is, that's Suboxone. So that medication is actually being used to treat the opiate addiction. So that number doesn't bother me. That's actually what we would like to see rather than fentanyl or any of these other medications. We want buprenorphine to be the most commonly misused. Now, people may disagree with me on this, but I will tell you in my field, they call it misuse because I can tell you people who come into treatment for opiate addiction and withdrawal have often tried Suboxone on the street. Okay, so they've actually taken it from a friend or taken it or bought it from a dealer to help them detox. Now, I know I don't like diversion and I don't want that to be happening on the street, but I'd rather have them trying to take something to help them detox than actually trying to detox with fentanyl or something else. So there was actually a study done years ago where they tracked the diversion of buprenorphine. It wasn't a very well done study. The diversion of buprenorphine on the street actually reduced the number of opiate death overdoses that same month. So meaning the more Suboxone and Narcans that we get on the street, the less overdoses they were. So I don't want to promote diversion, but I don't mind the fact that these because most individuals who come to see me are educated or at least have tried Suboxone or buprenorphine and getting it from somebody on the street. So it's just interesting that that's tracking the data, but at least it shows that we're trying to get that out of there. Fentanyl, you can see now that's the most common one. The other pain relievers are getting more and more difficult to obtain. Unfortunately, if you guys hadn't heard, from 2000, what's that?
Dr. Willey, we have a couple questions.
Sure.
So one question is Suboxone the same as methadone?
It is not, and I will go through all of that on the MAT section, and I will go through all the different options, but Suboxone is not the same as methadone. The other question?
Yeah, the other question was, so somebody wanted to know your thoughts about using THC for reduction of the use of opioids. They were at an APA conference a couple of weeks ago, and there were some presentations with research about how THC is the future solution to resolving the opioid addiction.
Well, okay. Now, I'm not totally opposed to that because, I mean, that's a controversial topic, but again, it does make some sense. Now, THC is a broad structure. There are hundreds and hundreds of cannabinoids within cannabinoid within that plant. Now, there's hundreds of those. Now, it depends if you're talking about Delta-9, which is kind of the psychoactive one that most people use, but is there medicinal value in those cannabinoids that reduce restlessness, irritability, cravings? Of course. And I've seen that. And in fact, I've had patients in here who have used edibles and cannabis and different, just even CBDs to help minimize their withdrawal and their restlessness and their cravings and irritability. In fact, I have one in my outpatient right now who swears by it. So I'm not one of those people that is going to sit there and say that's a terrible, horrible idea. Are there safer strategies? Yes, I'm going to stick with the evidence-based science that buprenorphine, methadones, and those type are at least for now, because these are new studies. Like this country finally got wise enough to actually open up THC and cannabinoids for actual real research. And that was a good thing for us to do. That research, how it's being done, and it's good to see it's like the APA and those type of things, because that's actual science research, evidence-based, that we can, controlled studies that we can actually tell what to use, how to use it, right? Because most of the things with cannabinoids are anecdotal. Or if you read a study, it's a case study, this works for this or this works for that. We don't really know how much dosing or what type of strain and so forth. So is there hope? Is there potential there? Absolutely. Because when we first legalized medicinal cannabis, guys, in this country, this is kind of for those of you who ever smoked pot in college and other places, like when the people who were making these laws, the first thing that they did is open up the cannabis for medicinal value for anything that a doctor wrote for. And they allowed those individuals to purchase up to 1/8 ounce per day. Now, I don't know how many people are familiar with how much 1/8 ounce, but that is a lot per day, meaning we're kind of not ignorant, but just unknowing for the people who actually started these processes And it's finally getting into scientific studies to where, yes, they can actually study the effects of opiates. I have seen people talk about that topic, and for me to be rambling on, but obviously there is potential there. But still, I don't think that they, in my opinion, will they ever be as successful as this to the true substitution that we're doing now with the success rates. Probably not, but we'll see.
There's one more question, although it's kind of already answered in the chat, but what is hydromorphone?
That is Dilaudid. Now, if anybody, hydromorphone is old school. I say old school, Dilaudid. Demerol is even older, old school. I don't know how old everybody is here. I'll be 50 this year. Like when back in the day, it was called vitamin D, was for Demerol and Dilaudid. That was kind of the holy grail of what opiate users went to emergency rooms to seek out. Demerol causes seizures. One of the only, we don't see Demerol anymore. In fact, it's pretty much off the market for good reason. Dilaudid is a very high potent opioid that people still seek after. I hadn't seen it for years, and all of a sudden the last couple of years, I'm seeing more people saying they're using Dilaudid. Now, here's the thing. The dealers are manufacturing the fentanyl into every one of these pills that look like those. So imagine, I don't know if they're being prescribed or they're just purchasing off the street thinking they're Dilaudid. And then another one on here probably talk about that people gets overlooked and not talked about enough is tramadol. Is anybody, for people familiar with tramadol? I'll talk about tramadol because I'm going to, full disclosure, tramadol probably kicked off my opiate addiction when I was in med school. Nobody's fault. I take full accountability for my messed up thinking and behaviors back then. But tramadol somehow evaded the controlled substances when it got approved for pain control. So what they thought was this was the perfect go-between between ibuprofen and Tylenol, codeine, and then oxycodone. So it's like a non-controlled, less addictive type of medication that people were using and giving to people right and left. So when back in the day when I was in med school, the reps used to come and just bring boxes of meds for samples. And many of us took them to try them. And tramadol is a very nasty opiate because it's called, we call it dirty because it hits so many receptors, including serotonergic receptors. And it's one of the only opiates beside Demerol that actually causes bad seizures with overuse. And we get a lot of that. So people think tramadol is a benign drug. It's not. It is now controlled. And I've treated probably a half a dozen serotonin syndromes when I was in training, and almost 5 of the 6 involved tramadol. So it's something, if any of the providers are out there, my medical, I educate my medical team here on the use of tramadol because they still prescribe it. It doesn't mix well with psychiatric medications at all, so I try to avoid it. Any other questions? All right. All right. Now, the bad news with the pandemic, right? This is unfortunate. 107,000 more in 2000, more than 107,000 died in 2021 during the pandemic. What was unfortunate about this is that before the pandemic, anybody tracking this data know that we had the first decline in overdose death rates in 10 years before 2018. So this is unfortunate during the pandemic that it actually accelerated things the opposite way. And 70% of those are related to the opiate overdose death rate. I mean, so from fentanyl and opiates. Now, this kind of chart mimics what that says. If you look at the different types of substances contributing to the overdose death rates, you can see that light blue line is the highest peak, synthetic opioids other than methadone. Okay. And they say that methadone is because they're saying about synthetic opioids. There's difference between opiates and opioids versus what are naturally derived from the opium and heroin versus what are synthetically manufactured in a lab, such as methadone is one of those, and so is oxy, so is obviously fentanyl. But you can see this huge peak on the fentanyl, and so that substance itself has accelerated the overdose death rate significantly over this past couple of years. I gotta see again. Put this again here, 91,000. This was in 2020, so this was the year before. Again, in 2018, you kind of see that little dip there in the lines, and we were encouraged because we were starting to get medication-assisted treatments out there. We were trying to educate, but unfortunately, this pandemic really hit things hard. involving any opioid, you can see that 68,000 of that 90-some thousand. So we're looking at about 70%. So that's 7 out of 10 of those overdose death rates involve synthetic opioids. Prescription opioids, you can see, again, prescription opioids in combination with the synthetic opioids. When they say other than methadone, they're referring to fentanyl. You can see the yellow curve again is accelerating during this time period, whereas the prescription opioids without any other opioids has gone down. And we'll talk a little bit about why that is. Anybody going to guess why that number is going down? Largely because they're harder to get, right? Because doctors are, the pendulum has swung both ways, and I won't get critical of anybody. That's just the way we react. But getting people prescribed just regular opiates anymore is very difficult, even for those people who need them. Unfortunately, I'm getting a lot of really bad chronic pain patients who become dependent, not necessarily addicted behaviors, but dependent on pain medications because of their chronic conditions, osteoarthritis, rheumatoid, number of injuries, surgeries that are being taken off these opiates, or doctors have just gotten so weary of prescribing the opioids because of the legal ramifications and the addiction and the opiate epidemic that they're getting harder and harder to get. Okay, involving heroin, you can see heroin also going down, but heroin in combination with fentanyl also going up. Now, this is a little bit of my spiel on, has anybody heard of, and somebody probably some out there have heard of the 3 waves. We refer to the 3 waves of the opiate epidemic. The first wave starting in the early, late 80s or mid 90s, we'll just call it, was the first rise in the opiate epidemic. Now, what was being prescribed back then were pain pills. So the first wave of this thing was pain pills. Now, we can sit there and talk about blame all we want, but there's contributing factors during that time. We have a country that consumes 90% of every opiate in this world. We prescribe pain medications for non-fatal terminal illnesses, unlike many other countries. We are one of the only countries that allow direct-to-advertising consumers, except I believe for it's either Venezuela or New Zealand, for pharmaceuticals. Reps, we can blame Purdue Pharma. If anybody has not followed that or seen the documentaries, Dope Sick's a really good one, dramatization with Michael Keaton. If anybody hasn't seen that, it's well done. A lot of good documentaries. The greatest crime in the world was another one that documents how poorly and how bad and how crooked this whole thing was with OxyContin, which started it. Now, those, for an education standpoint, before OxyContin, we knew back then it was morphine sulfate cotton called MS cotton. We knew it was addictive. The country knew it was addictive, but what they did is Purdue Pharma had a new vehicle for an extended release formulation that they put oxycodone, which is basically what Percocet is, into a long sustained release formulation. So you only had to take 1 pill a day. And so what happened is they put that into that formulation from the MS cotton and they made OxyContin. What people didn't realize is if you, instead of taking 4 10 milligram pills throughout the day, you just take 1 40 milligram. Well, what happens is you crush that, snort it, and so forth, you get a huge rush of OxyContin. And that's what started this epidemic. People were getting very rapidly addicted and very dependent on these very quickly. During the same time period of which Purdue Pharma was claiming this was less addictive, they got special language through the FDA, unfortunately, to promote their medications less addictive. Doctors were educated poorly on the less addictive qualities of OxyContin during that time period. And so we started prescribing opiates for everything. They started that, if you've watched the documentaries, in blue collar areas of the country, mining, where people had significant back injuries, people in coal mining and so forth. And they targeted, unfortunately, that Appalachian area where people had chronic pain symptoms, and then it blew from there. And not to get on this whole thing, but if you watch those, those populations, those small populations consumed more opiates than huge metropolitan cities, and nobody said anything. So we knew what was going on, a lot of crooked practicing, a lot of pill mills, a lot of bad prescribing. And then a lot of people got caught in that weren't all negative. Everybody wasn't bad, but what happened with opiates being prescribed was eventually, and this is what we're seeing with the opiate epidemic that people have to understand and realize, is there was a whole population of people that were prescribed opiates for a long period of time that had no idea that they were going to get dependent or hooked on these pain pills. And that doesn't make them an addict. And that's partly why we changed the language from addiction and call them addicts instead of opiate use disorder. I treat people all the time. In fact, I had 3 here this last week that have no addictive personalities or behaviors at all. They were just on chronic opiates for so long and then all of a sudden got cut off and now they need help. Now, but people, as you take opiates over and over again, you develop a tolerance. And our language, even with the diagnosis of opiate use disorder, has within it dependence and tolerance. Because if you take any kind of opiate over and over again, or psychoactive substance, your body's naturally going to develop tolerance. And what happened in the pain clinics is people kept getting more and more medications being prescribed. The concerning thing during that same time period is when they looked at the functionality and improvement and quality of life, it didn't change. And that became a problem. So when people came in, they kept getting higher and higher and higher doses because they're less effective. I will tell you, one of the most difficult rotations I ever worked in was the pain clinic at KU during this period when we started to rein in the opiates. And trying to get people off their pain meds and getting them off them was very difficult and uncomfortable for a lot of people. People were angry, people were mad, but it was not an easy time. So that was the first wave. And then all of a sudden we found out how addictive these were. Doctors started getting sued. They opened the liability. Pain clinics, pain pills got the pill mills got closed, especially down in Florida. If you haven't seen that, that's a whole nother show where people were just flying on planes down there right and left to go to the pill mills. But we finally got a hold of that and reined it in. But what happens if you take away one substance, the opiates, what do people do for the second wave? All those people who were chronically on pain medications for that period of time or addicted transitioned to heroin, because as the opiate epidemic at the end of the first wave, supply and demand took over. And that OxyContin pill became about a price of $1 a milligram. Okay, so this will lead into what's going on today, what you see with these fentanyl pills. At the end of the first wave, they were increasing the price of oxycodone and opiates to $1 a milligram. Now, how many people can afford a 60 milligram pill a day, which is one pill for $60? What happens? They can't afford it. We rein it in, supply and demand. People migrated to a cheaper alternative. And what was that? Heroin. Okay, so the heroin became the second wave of the opiate epidemic. Overdose death rates went up. Why? Because heroin is more fatal and more difficult to manage than the pain medication. So they started using heroin. Heroin took over for the next 10 years. What happened? What is heroin derived from? Do we know? Opium, poppy seeds, right? So it's an agricultural crop. Southeast Asia, the Golden Triangle. Now, if you're a drug dealer and you're a business dealer, which is drug dealers are in it for money, it makes natural sense for them to migrate away from an agricultural crop that has to be produced halfway across the world, cultivated, shipped in, when you can synthetically manufacture a powder in a lab that's 100 times more potent, doesn't taste, doesn't weigh as much, and you can mark up your bricks, smuggle, and easier to smuggle into countries and for use. So they migrated away from heroin to fentanyl because they can make a lot more money. It's a lot easier to smuggle and they don't have to rely on the agricultural crop halfway across the world. It is all business. So that's what they did. So what happened when fentanyl came in? It came from China. So the US cracked down sort of on China by making fentanyl production illicit, but they did not make the precursors illicit. So China is shipping the precursors to Mexico. And Mexico is producing all the fentanyl. And now they're flooding it into our country, and it's coming now from Canada as well. And so when heroin got replaced by fentanyl because it's cheaper, easier to make, and more potent, this is where it got very, very deadly. And that's what we're seeing today. Now, as that synthetic market morphed over the past 5 years, you can see this huge peak in the 2020 and 2021, not just because of the epidemic, but because they are making more and more derivatives of fentanyl itself. Okay, so what is fentanyl in itself?
Oh, wait, Dr. Willey, we have one question.
Go ahead.
Where does gabapentin fit into this?
Can I table that and talk about later? Gabapentin, I'll just talk about it now. That's fine. That's why I want you to ask questions. Gabapentin is a GABA analog. And if people don't know what the GABA system is, GABA is the parasympathetic, keeps us calm, right? So alcohol primarily works on GABA receptors, benzodiazepines works on GABA receptors, and so does gabapentin. We're not really sure how the mechanism, but basically it's a GABA analog. Gabapentin is used primarily for, it's FDA approved for diabetic neuropathy, pins and needles, sciatic nerve pain, shingle pain, because it helps settle or lessen the firing of the nerves. Okay, so it works very well for anxiety and nerve pain. Now we use it very commonly in substance, primarily alcohol and benzo withdrawal. People use it in opiate withdrawal. I'm using it in here now because it helps people with the restless legs during that time period. The trouble with gabapentin now, and gabapentin had a recent study last year, reduced alcohol relapse by 52%. Now it helps substitute, again, it's a lesser strength than a benzodiazepines, but people have started misusing gabapentin. And gabapentin is now on our prescription monitoring drug program, electric prescription monitoring, KTRAX. A lot of treatment centers do not allow people to take gabapentin anymore because people will start misusing it. And I do get people in here admitting that they'll misuse it because they'll get a sedation, euphoric sedation out of it. But that's what gabapentin is, but we're using it primarily for anxiety and detox symptoms, if that answers the question. Okay. Fentanyl. Now, what was fentanyl was initially designed as an anesthetic, an anesthetic for surgery decades ago. They were looking for potent anesthetics and analgesics back then, and it worked. It's 100 times more potent than morphine. It works on all the opiate receptors. It's highly addictive. I always say it's like my cocaine peak. Anything that hits fast, and lasts a short period of time, what do people tend to do? Do it again and again and again. Develop tolerance quickly and subsequent withdrawal, analgesia, euphoria, CNS depression, which causes the overdoses. Meiosis just means pinpoint pupils, and then respiratory suppression, which is the danger part here. Okay, now this is why this peak has largely accelerated the way that we see it, because look at all these derivatives, 40 plus. So these dealers, right? These dealers are making not just fentanyl, they're out to make more new, fancier and more potent fentanyls. And there's 40 some derivatives. Some of them we cannot detect. And this continues to evolve. That's the dangerous part about what's going on with people taking these pills. They don't know which one and how much is in which pill. That's the scary part. This is a good graphic. This is the carfentanil. This is that's a dime. As you can see, that is a lethal dose. Now you can imagine the dealers are not lab techs. They're not educated. They're not sitting there in a pill in a scientific lab measuring out how much substance is in each pill that they press. So you never know how much of which substance of which is in each pill or powder that they're taking. And that's all it takes. The carfentanil is the one they used to tranquilize rhinoceroses, elephants, and so forth that got pressed here about a year ago. Jamie was just talking to me about that there's even a new designer. We talk about designer synthetic derivatives, this isocytanazine, which is ISO, which is tri-state area, Florida now, and Colorado, is even 20 to 100 times more potent than fentanyl. So you're talking as much as 1 to 2 grains of this stuff is deadly. And in fact, if you hear about law enforcement or paramedics showing up to scenes, and if they even get a whiff, inhalation, or through their skin, they will have respiratory suppression and need to be Narcan. That's how deadly these things are. Even in Kansas, we're not immune. I will tell you right now, we are flooded. This is the worst I've ever seen it. Again, I'm not here to be a doomsdayer. I remember, this isn't because I like to say like I'm right. Unfortunately, I was, just because when I gave a talk with I can't remember who it was, a task force 4 or 5 years ago with Johnson County back then. We were talking about opiates initially. And I talked about the synthetic derivative market that was going to morph into these opiates, and that's exactly what happens, just like any other substance. And the drug dealers now remember what I talked about of why people went to heroin, because the opiates were 50 cents to $1 a milligram, right? So why is the drug dealers forming the powder, transforming the powder, pressing the powder into all these type of pills? It's always money, because they can get more money for a pill than they can a powder. So these are going for about $15 a pill right now, from what I call them my kids, my younger group in here I got a good relationship and they're brutally honest with me, but they're getting $15 a pill. They used to be 20 to 25. And now the powder's coming out again, that they're getting this pure powder, but with these different derivatives. The deaths that you're seeing, unfortunately, I always get terrified when my people, I don't like to call them patients, my individuals in here tell me that, well, I'm being smart about my use, so I won't overdose. My one kid in here has had 14 overdoses. One just came out of an ICU for 4 days because he took a pill that had some type of fentanyl and he didn't know. The other one was testing for benzodiazepines in his fentanyl pills that he didn't know that were there. And they're mixing even animal tranquilizers in them as well. The kids that have died, unfortunately, here in town too, not more commonly, but it's scary too. They're buying not what they think to be pain pills. They are buying what they think to be Xanax. And if these Xanax bars are fentanyl. So they've just decided they're going to put fentanyl in everything, and now we're putting out the fentanyl strips at least, which is a good idea for people to test. Again, harm reduction that we'll talk about, but people are buying pills that, for different reasons, even Adderalls and Xanaxes that they don't realize have fentanyl in it. And unfortunately, you don't know which derivative, which type of fentanyl, and how much is in each one of those pills. Those dealers don't care, and they're not measuring it out. And that's the scary thing about it. All right.
And
Now,
Dr. Willey, to kind of go with that, so we have a question about, are there common false positives associated with fentanyl use as far as drug tests go? We see positives for LSD when there is fentanyl detected.
say the last part again.
We will see positives for LSD when there is fentanyl detected.
Yes and no. I mean, the answer is yes and no, because I had to put forensic testing in our facility for that exact reason. Like I had to step up our game to GC mass spec and stuff, that because there's so many derivatives and things that we can't detect by normal drug screens. Here's the scary part. Most typical drug screens do not detect fentanyl. You have to have a specific fentanyl test. No, there's more false negatives than there are false positives. Like I've had people, the kid that was in the ICU, the other one last week, we couldn't test for everything was negative. Meaning he was taking something, he ended up in the ICU for 3 days and we had no idea what he was taking. And the people that are in here now, most commonly, they will either have false negatives where it doesn't show up, or they'll have positives for various substances like what you're saying, because they're mixing it with all kinds of different stuff. But typically LSD is not one that I've seen out there. But yes, you're going to get both. You're going to get false positives because of what's being mixed in. Like I said, I just told this, the one person in here had an overdose. Well, he tested positive for benzodiazepines. He didn't know that there was a benzodiazepine derivative in his fentanyl. Then he bought a different batch and the benzodiazepines were negative. So you're going to get more negatives than positives, but anything's possible the way they're mixing things together.
And then one other question, how long does fentanyl stay in the system?
Not very long, like 12 hours. You can't, it's very hard to detect. Back even when I was being monitored for my fentanyl addiction 20 years ago, that was part of the issue. It's like it's very short acting and it doesn't stay in the system very long at all. Any others? All right. Now, this is kind of a concerning, like just of our population. If you look at it, it's kind of, we'll talk about like, stigma and stuff, but like this isn't the same study. Look how many felt they need treatment and made the effort, 0.5%, and didn't get treatment is only 2%. Of the people who qualified on the National Drug Survey, this isn't humorous. I mean, it's just staggering to, it's 97.5% did not feel they need treatment. Meaning, what is the issue? Why do people not wish to seek treatment? A lot of people don't want to admit they have a problem, acknowledge they have a problem. And a lot of people, this is the honest truth, a lot of people, they don't want to completely stop. We have this abstinence only based model in this country for a reason, and that is there for a reason. But people do not want to go be told they can't do these things anymore. They usually wait till the very end when there's all kinds of negative consequences and they're forced into treatment. Very rarely, and I always appreciate the people, I always give them props and credit. I'd say only about 15% or 20% of people I see in treatment are actually raising their hands saying, you know what, I feel this is becoming a problem and I want to get ahead of it. Most of us have dire consequences by job, work, overdose, health, family relationships that get us kind of forced into treatment. But many people don't feel like they need treatment or they can control their use. You got to remember, we're humans. and we like control. And we don't like to give up control. So this whole surrender to win thing is very contrary to how we think. Because so we want to get, so when people, we get even out of, when people get consequences, start using, and they get addicted to these substances and have negative consequences, even when they do get treatment, guess what? Thank you, Dr. Willey, Cottonwood, Johnson County, all of you out there for getting me, feeling better again. I'm just going to be smarter next time and manage it differently. So I don't have these same problems again. And that's why the number of treatments we go through is about 4 or 5 times. Okay. Another cartoon. All right, and this is just, again, between substance use or mental illness. I just wanted to discuss the overlap that we talked about of why it's so important for people to talk about the substance use. You never know when you have a person that's willing and at a moment where they may say, you know what, maybe I should talk to someone, or maybe I do need help. So always make sure you do, because there's such a huge overlap between mental psychiatric conditions and substance use. And I think, statistics, I don't get caught up on statistics. Like I said, generalization. I've been doing this a long time now, and I will say it's very rare for me to manage somebody with a substance problem that doesn't have a co-occurring psychiatric conditions, because often people self-medicate, right? People migrate to a drug of choice for a reason. And people with anxiety conditions or depression, for example, often migrate to alcohol because it helps, it relaxes. And then nextly that tolerance goes into dependence and it gets them into trouble. But there's a huge overlap between the two. And this is, kind of disheartening statistics again, but if it's substance use treatment but no mental health services, only 2.5%. No treatment, over half the people who qualified didn't get any treatment at all. Only 5%, 6% got both. And even mental health treatment, only 50% who said they had an issue or had a diagnosis even got treatment. Now, what's getting the barriers? This is something to talk about too. Amongst adults with co-occurring conditions, didn't receive mental health care reasons, couldn't afford it, didn't know where to go, could handle the problem, fear of being committed, cause the neighbors to have a negative opinion, that's the stigma, didn't think treatment would help, don't have time. Confidentiality, those are big things, and that's a stigma that we talk about. Didn't receive substance use. What the biggest one? Not ready to stop using, right? And I'm going to talk about this in the MAT section about kind of strategies that UK and Europe are doing to get more people engaged in substance use treatment. They're kind of preaching their harm reduction model, saying, look, we know you're not ready, but come talk to us and let's try some medications like naltrexone and Vivitrol that could reduce your drinking. And it's getting a greater number of people to at least walk through the door and say, let's talk about it. Because again, everybody wants that control back and hopes they can get that control. Health insurance, we could talk about this all day long about health insurance and couldn't afford cost. Health insurance is a necessary evil. People know me that I can get pretty fired up about both sides of this thing. They're a necessary evil, but unfortunately, I don't believe they have our best interest of their patients, individuals, for mental health and substance at all. There is a huge silo still within those organizations. Fighting with them every day to get adequate treatment. Duration of treatment is an ongoing battle. I will tell you, it's not a positive of any way of the opioid epidemic, but I will say when I started here, I could not get a single individual admitted for an opiate use disorder at all. They refused to pay at all, saying they could manage an outpatient, which is extremely difficult to do and extremely dangerous, especially today with these high dose fentanyl. Because people who come in with withdrawal from fentanyl, let me tell you something, you could tell me I could send them to their pharmacy and titrate Suboxone and tell them to show up for 6 hours of class the next day. And I'm going to tell you right now, they don't do it. They can't function. Like they need a place to come in, to rest, to get the medications, to get them started. And only in a matter of a few days, you can get these people turned around really quick. I will say I'm glad to hear and see that now most insurances are allowing me to have people in here for a few days to get them stabilized, because they could see that they weren't engaging and not able to function in groups when in an outpatient setting, like they needed a few days of rest and to get these meds going. And so at least they're allowing that, except for Medicaid. This is something that this is off topic. Like, it's unbelievable to me that Medicaid in this will not cover opiate detox. And which is an unfortunate thing, which I don't know how to escalate to get that fixed for, but with these younger kids becoming more and more younger every day, trying to get treatment for opiates, their options are limited. I know Heartland and KU and people are working with them and doing a good job, but it shouldn't be that difficult to get help. The stigma, we have stigma against ourselves, not just in this country, against people with substance use and mental health. The opiate epidemic, again, I think things have gotten so prominent that most everybody either knows somebody or has been affected directly by somebody with substance use. So it's becoming more and more topic and more of a conversation, at least. People, and I think it's gotten a little less. But even those who come into treatment have a stigma against ourselves. I have to talk people up all the time. Here's my example. Like, if people come in, most people will come in strictly because physically they can't function anymore, and they'll come in for detox. I will get that person detoxed and managed and feeling better. And guess what a majority of them want to do? They want to leave, and they don't want to do any kind of continuing care, of which is absolutely essential for any time of sobriety. And many times of the reasons because they're worried about what people will think, including their job. And my analogy, I always tell them, I'm like, I know this is difficult, but here's my analogy. I'm not your psychiatrist. I'm not your addiction doc. I'm your cardiologist. You just had a heart attack. I'm your neurologist, and you just had a stroke. And you're in a hospital in your ICU setting, and you've lost some function, and you can't lift, and we're going to have to go to physical rehab, and we're going to have to work on things because physically you're not able to return to work for a few weeks, month, whatever it is, till we can figure this out. There are FMLA, there are policies in place, there are things to protect you and to allow you to do that safely and legally. You are protected under the same aegis, under that same paperwork for psychiatric and substance use, but we have a stigma against ourselves with addiction because we're like, if it's alcohol or substance or depression, it's something we caused. We shouldn't have these problems. I caused this, it's my fault, so I can't take the time off work. I can't ask for help. I can't do these things. Sometimes it works, sometimes it doesn't, but I continue to try. Treatment options are limited. You guys some of you are on this coalition, especially with adolescent treatment right now, is so difficult to find, and not just in Kansas City, anywhere. The insurance coverage and treatment types, we're trying, but there's not enough options out there. Okay, let's see. All right. So do we need to take a break, or we just keep going? What do you think, Jamie?
We're good. We can just keep going.
All right. So we'll get to the treatment strategies here. Okay. So enough about that. If you have any questions, just send them in to me. But treatment strategies to address the dangers of substance use and opiate use, to stigmatize the addiction and treatment, education, public awareness. That's just what we talked about. We need to get people out there. We have changed the language, as you know, in the DSM-5 to substance use disorders. We can treat people who just have dependence on these substances, not necessarily addictive behaviors that we think about. The face of the substance use person has changed a little bit over the decades, increasing access to evidence-based treatment, reimbursement, insurance, number of treatment programs we just covered, expanding medication-assisted treatment. Okay, and this is what we'll emphasize on the end. These are essential, these are essential, especially when it comes to opiate use. And I talked to Jamie about it a little bit before. The data continues to be overwhelming when it comes to opiate use disorder and medication-assisted. We're changing the treatment to therapies to even so you can make it more generic. Without these medications to assist with treatment, our success rates are less than 5% in a year. Increased psychosocial recovery support, counseling, mental health, family involvement, monitoring services, length of treatment, right? Gosh darn it. Like, we know that 90-day treatment equals much better outcomes than 1 week or 3 weeks or 4 weeks, but getting anybody to cover for it or pay for it is nearly impossible. Okay, ongoing research, like I said, the data continues to come in daily in regards to treatment, the medications, the duration, the dosing, and availability of Narcan. You guys know, hopefully people know what Narcan is, but at least we'll talk about how important that is and how much we need to keep distributing that as much as possible. All right. Prevention, first step, right? Promote appropriate prescribing. We have rightfully so, and in this country, back when I went to med school, this isn't a knock, most med schools, we didn't get, it was the opposite. We didn't get any education on prescription, opiate use, prescribing, the dependency, any of that. In fact, we were prescribing these medications. It is now mandatory in nursing, medical schools, and so forth. And now, like even the state of Kansas has mandated for licensing to go through an opiate education course every year, which is a good thing. Fight abuse and fraud, safe disposal. I always brought that one up there because, like, where do most people get their opiates from for the last decade was actually from a friend or relative, and most commonly in their medicine cabinet. Like if you see medicine cabinets just full of bottles all the time when you go to parents or other family members, and that, it's amazing to me that in the last 5 years they finally started making awareness of disposal because nobody knew what to do with their medications. And it's amazing to me when people come in for treatment, the bags of medications they come in, it's like 20 to 30 bottles. So where do you get rid of those? Safe disposal. I think Walgreens, CVS, all those have days now where you can just bring in your medications. KU does as well. Increase awareness and dangers, treatment, increase access to care, doctor education, like I just talked about. This is huge. This is part of me while I do this. I feel it's an obligation. I enjoy the look and the response I get from my own doctors, even in my hospital, that are not fully on board with MAT or prescribing. And I give them education and say, just do this, and how quickly they see the results and how well it works. They come back to me and they said, oh my gosh, this really works. Adapt coverage, data insights, identify trends, increase access to care. All right. Now, this with the pandemic, this is, for some people, this may affect who are considering MAT. If there's any providers out there, this is something that I'm actually looking into right now. Now, during COVID-19, what did we do when we had the offices shut down and people couldn't get their medications, right? Telehealth. Now, does anybody know what the Ryan Hyatt Act is? It was an act enacted, rightfully so, years ago after somebody died from getting prescribed controlled substances from a doctor over telehealth with no in-person visit, right? So in this country, you have to be in person with physical examination and so forth for right reason to prescribe a controlled substance such as an opiate, even Suboxone. Now they they alleviated that rule during the pandemic because we needed to get people Suboxone and other medications. So they leveraged telehealth for prescribing MAT. That's a good thing. Now, why is that just a good thing for the epidemic? How about rural areas in Western Kansas and Nebraska and places who don't? Like there's a statistic up there, like how many counties in this country don't even have a provider? How do those people in those countries or those counties get any kind of access to healthcare MAT? Let's do telehealth. So what we'll try to do is have one nursing visit, one place on the ground, boots on the ground, an individual visit, do a physical exam, induce the Suboxone or medications, and then have follow-ups via telehealth. Providing prescriptions and refills to stable patients without in-person visits or toxicology screens. Again, not the ideal situation, but we have to adapt. Ideally, yeah, we want to have tox screens and urine drug screens every visit and follow up, make sure. Bottom line, it's not necessarily always possible. So we made some alleviations and some loosened the criteria. Counseling should not be required, even though it's essential. Adequate supply and refills of medications, access to Narcan, which I'm proud to say in this state and the country that we've done that with a standing order through pharmacies and getting it out to everybody as much as we can, and special considerations for high-risk patients to continue access to treatment. All right, this is what I was talking about. The Department of Health Services on HIPAA compliant technologies. We allowed telehealth. Now, what for addiction prescribing services? This is ongoing today. Now, the question is with this epidemic or the epidemic within the pandemic or the pandemic, however you want to say it, is how is this going to move going forward? Because it did help, and we found out it saved a bunch of lives, and people are getting medications and getting access to care they didn't. The question is do you stop? Right now that we're coming out of the pandemic a little bit, do we allow prescription services and addiction services over tele to continue? For right now, each state is taking it a state by state basis, but as of right now, everybody's pretty much saying yes. Now that allows me to prescribe Suboxone to anybody in any state in which I have a license. Just so you guys know, that may be more than you want to know. So let's just take Nebraska, where I'm from. If I wanted to treat somebody in Nebraska, I could do that over tele, but I would have to have a license in Nebraska. If I did it in New Jersey, in South Dakota, same thing, wherever that state. So the medical boards have created multi-state licensing applications for us that we can get multi-state licenses to allow us to expand our services. Now, as on the East Coast, what they're doing, and I don't disagree with, is they're allowing the teleservices to continue, but they require one in-person visit per year. So is it ideal? No, because when somebody's detoxing, when are people at the highest risk from opiate withdrawal and overdose? When they're first coming into treatment, when they're going through withdrawal. So I like to have people around them, people seeing them as much as possible in inpatient settings, but in a pinch and in this pandemic, we'll take what we can get. All right, this was a little tongue in cheek because this didn't happen. Does everybody, I'm sure people have heard of the X number, the X waiver. The X number is something that is required for a provider to prescribe Suboxone or buprenorphine. I do not agree with it. There's a movement in this country to get rid of it. It should be. If you want to talk about a stigma, you guys, if you've heard me talk before, I will tell you this is a stigma within our own health system right now, because there is no reason that I should have a special requirement to prescribe Suboxone or buprenorphine. If they want to put a restriction on things, put it on OxyContin, put it on Dilaudid. And instead, what we did is for people like us who want to prescribe a medication that saves lives, to go through a special treatment, and for that special training on a very safe to use and easy to use medication, I can treat as much as 30 people my first year, which is the most absurd thing I've ever seen. Which means this is the only limited medication that the only prescription on the registry of which you can only prescribe and treat 30 people your first year. Despite this epidemic, you can only do 30, which is just insanely restrictive and not necessary. Do this to the medications that are killing people with the opiates themselves. But they're starting to track that as well. But the X waiver is a requirement DA registered physician and allows us to do buprenorphine. After 1 year, I can increase that up to 100 patients per year. Again, there should be no restriction. If you're trained and you're doing this for the right reasons, and it's not a difficult medication to prescribe, it's easy. But that's the X number. Now there is a movement to get this X waiver alleviated. Why? Because a lot of providers won't even go down the MAT road because they don't want to deal with this. They don't want to deal with training. They don't want to be on a registry. They don't want an X number. So we're trying to make it as easy as people to get involved because there's not enough of us prescribing these medications. But unfortunately, the Biden administration, I'm saying the Trump administration put this through to say they wanted to eliminate the X waiver requirement for DEA registered physicians. The very following week, the HHS and the other administration came in and said they overstepped their bounds and we're not allowed to do that. And so now we're kind of in this, are we going to do this or not? So just stay tuned. But that's what an X number is. And all that means, that X number is good for every state and every country. I just put my X number as my first DEA number and I can prescribe Suboxone. All right, so we'll talk about the medication assisted therapies that we get into. Why medications? Chronic brain diseases, substance use treatment disorders are like any other chronic disease, respond best to comprehensive treatment, require long-term treatment. Medications improve treatment outcome over interventions, psychosocial interventions alone, prevent complications of withdrawal, facilitate engagement. Like I said, I'm telling you right now, if I can't give my individuals coming off of fentanyl or alcohol or anything else, medications to alleviate the physical withdrawal, they can't engage in groups, reduce cravings or risk of relapse, protect against opiate overdose, and can reduce overall mortality by more than 50%. And that's astounding. Now, I was talking with Jamie too about this too, like with harm reduction and our stigma against substance use, like we have to look at substance use as chronic medical conditions, just like diabetes and hypertension, and the relapse rates and non-compliance rates are just the same with substance use as they are with these other chronic conditions. But we have a stigma in this country as if we're not trying, it's our fault, it's not our willpower, but it's the same as these other conditions. And we have to try to see it that way. the best that we can and treat them as chronic conditions. This isn't something that somebody can come into a hospital for a week and have treated or go to a 30-day program. This is a lifelong. I always tell my patients, there's no diploma, there's no graduation. This is a lifelong condition that you're going to have to manage the best that you can. I'm not going to get into all the scientific stuff, but basically this is kind of the diagram you guys can look at if you want of addiction, progression of addiction, and what they're doing with modern day technology and science is trying to target these certain receptors and neurotransmitters with different medications to see if they can alter the addictive brain or the addictive tendencies. Now, what medications are out there? We'll focus on the opiates, but I don't want to there's not a ton. That's the thing. Like alcohol, still the most primary, biggest condition in this country by far. There's Campril, Antabuse, and Vivitrol, which we use for both alcohol and opiates that we'll talk about. Opiate use disorder, methadone, the Suboxone, the naltrexone, and Vivitrol. Won't talk too much about the tobacco use, but hey, you should always talk about abstinence from nicotine, and then opiate overdose reversal. I will tell you, this is, I don't know if it's unfortunate is the right word, but I will tell you in substance use treatment facilities, what I've certainly figured out, even in my own hospital where I've treated, I pick my battles with nicotine and cigarettes. If you don't allow your individuals to smoke, they usually won't stay in treatment. So that's, I worked at the VA for many years, and those vets would just walk out every day, and it was over a cigarette rather than the alcohol withdrawal and so forth. So would I like people to quit? Yes, but I usually people will smoke while they're in treatment. So I kind of say we're gonna prioritize our issues first. All right, for alcohol, I'll just spend a minute on this. Campril is one of the medication-assisted therapies you may hear of or see. We don't see it as much in this country. It works on the glutamate excitatory neurotransmitter system that is getting more and more evidence and more studies. This medication, it reduces cravings in people, reduces relapse. I will tell you guys have probably heard my joke on this. I think they did it intentionally, but the dosage is 666 milligrams, which is 666 milligrams 3 times a day, which is kind of just interesting. And they obviously had to do that intentional. I've had people refer to it as the devil drug, and they refuse to take it. Some people swear by it, but I don't use it a lot. But you might be people. The problem with this medication, honestly, is asking anybody to take something 3 times a day is really hard to do, and it's still expensive. But you can see that it worked, 37% versus 17%. That was in the German study, so that's a 20% reduction.
So really fast, Dr. Willey, we do have a question of was that prior list of all the yes, that list. Is that the list for all medications used for MAT?
Yes. Now these are FDA approved. There are a ton of off-label. Gabapentin, Topamax, Remeron. I can go through a whole list, which I probably can put together for you guys too, but there's a bunch of off-label use. Now these were the FDA approved, studied approval list. Does that make sense? But we use heck of a lot more medications and for like the gabapentin is a huge one. Topamax reduces alcoholism and cravings better than I ever anticipated. Remeron for stimulant use as well. So, and there's a bunch of others, but this is the FDA approved list. The Campril we talked about. Naltrexone and Vivitrol I'll spend time on because we're using it both for opiates and alcohol. Naltrexone is the pill, Vivitrol is the shot every month, okay? Now this works on blocking the opiate receptor. Full disclosure, I took this med for 7 years back when I was in medicine from the fentanyl addiction for me to practice. Now, that medication sits on the receptor and does not allow opiates to work. Now, it's brilliant for opiate treatment, right? Because it makes you essentially immune. You can take a pill once a day or a shot once a month. What they found is that in alcohol use, it reduced cravings in about 35% of people, mostly in men, and it blunts the rewarding euphoric effects of alcohol. I could tell you that it works. I drank on it, and I could tell you that it did accomplish that. Now, this is what I was talking about in the UK and Europe, the harm reduction model. This is called the Sinclair method. Thomas Sinclair, if anybody have heard of that, he's kind of specialized in this naltrexone. What they're doing over there is they're giving everybody who to come to treatment to try to reduce their drinking, giving them naltrexone to either take daily, or they're telling them before you drink, take this pill. And the idea is it's psychological uncoupling. If they take this pill and they drink, they don't get the euphoric effects, then why drink more? Okay. And they're getting a significant reduction in heavy drinking and about a 25% abstinent rate. But at least it's getting people through the door and it's working rather effectively. Again, we don't have to talk about the numbers. There's obviously a difference between the two in the studies with relapse, and that's about 40%. That's pretty darn good. This is the long acting, right? We got the month. Now I know Johnson County, you guys are still doing, you still do the Vivitrol? I think you do. I think you have the Vivitrol injection clinic over there. I think you use it primarily for alcohol. This is the interesting thing about Vivitrol. As much as it seems like kind of a holy grail for opiate use and making us immune to opiates, I use it 9 times to 1 for alcoholism versus opiates. And primarily, I think it's because people with alcoholism, it's kind of what their substance is. People with alcoholism would rather start with something that reduces cravings and doesn't make them sick if they drink like the antabuse, like an absolute. They'd rather try a harm reduction first. And opiates are they're feeling so cruddy and having such bad detox and withdrawal symptoms, they'd rather use a substitution first, and they're not ready for a full blocker. The long acting works obviously better than the oral just because of compliance. That's why we use the shot. We have free shots here that we use. I gave one yesterday, and it will last for 30 days. This is what I said, the reduction in heavy drinking is much more significant versus placebo. Now, the caveat of that is when you talk to people with alcoholism about naltrexone or Vivitrol, they kind of eyes perk up and they kind of hope it's the holy grail that they can drink. Instead of 15 beers, they drink 7, which is a significant reduction, but they hope they can control their drinking again, which is what most people who come into treatment are hoping for, at least early on. People with severe alcoholism and substance use, they're just going to drink more and through it. So it's mixed results. Oh, that's funny.
So there are a couple questions.
Yep.
One is, so somebody said, you said you got shots for 7 years. Is that common?
I'm sorry, I didn't have the shots for 7 years because they didn't have the Vivitrol back then. I took the pill naltrexone for 7 years. Now the shot, I will tell you, insurance, they're costly. The shots, most insurances, they will approve up to 6 months of the Vivitrol. Is that, how they come up with those numbers, I don't know, but they'll usually up to 6 months. But
So
we can try to, go ahead.
Oh, that kind of goes to the next question. So is this something they stay on indefinitely, or do they get tapered off of it?
The Vivitrol and naltrexone, no taper needed because there's no substitution at all. It's just a full blocker, sits on the opiate receptor. There's no withdrawal coming off of it. Now, as far as duration of treatment, we stopped predicting, and rightfully so in this country. We have stopped trying to put everybody into the same box and say, this is how long you need to be on something and you shouldn't be on it longer. So it's patient specific. And I don't care how, I tell my patients all the time, I don't care how long they have to be on a substance as long as it's working. But at least at a minimum, we are finding with MAT, anything less than 6 months is detrimental. All right, antabuse. People have probably heard of antabuse. People have mixed feelings on antabuse. Antabuse was discovered decades ago in a rubber vulcanizing plant where the employers at the rubber plant were not able to drink alcohol, and they didn't know what was going on. They isolated what they called disulfiram or antabuse, which inhibits alcohol dehydrogenase, which builds up acetaldehyde, which makes you sick, which makes you hot, nausea, headaches. And it does reduce cravings. The studies do show that, but it also makes you physically adverse reaction if you drink. Some providers and some people do not believe in that philosophy in aversive type of treatments. I use it all the time. I think it can be highly effective in highly motivated individuals, and it's something that works. Back in the day, they used to use 3,000 and 4,000 milligrams when they did the studies at the VA. They found people were ultra hypersensitive, could get very sick. Now, what I would say, now we use 250 to 500 milligrams because the most common excuse, I'll call it an excuse that people will say, was like, well, I use hand sanitizer and I don't want to have a reaction to perfumes and stuff. The doses that we use today, those are very rare if happen at all. It's only if you intentionally drink alcohol will you have an adverse reaction to most people. Other people will claim that antabuse doesn't work. This was an interesting study because if you look at the number of percent remaining abstinent, less than 10% versus 40, 50%. Well, the interesting number is who took it and who didn't, right? So unfortunately, we don't have an antabuse shot like Vivitrol that lasts a month. Antabuse, here's the deal. People who take it usually stay sober. 80% of the people who prescribe it to don't take it because they just stop it. Now, I try to tell them I think it's a nice tangible reminder as a medication they could take every day. My sponsor used to say, and he's an addiction doc too, used to tell us individuals, look, here's your pill every day, and there's going to be days that you do not want to take this medication, and the day that you don't take it, just consider it your first drink, because that's the only reason that you either are aware or unaware of scheming to get a drink or have the option to drink. And that's true. We use this in monitored compliance in physicians and pilots and DOT and safety figures where we have to know they're taking it. We have somebody document that they watched them take it to assist with the compliance, because if people are compliant with it, they actually do pretty well. But most people you do prescribe it to will stop it, and they have to wash it out for a couple of days and start drinking again. But I do promote it quite a bit. Opiate use, okay, we'll end on this. So what's the high topic? This is outdated, and unfortunately, I haven't really found any data other than what we talked about, which we know it's much worse than this. I mean, opiate use, the mortality rate is much higher than this. This was back in, well, this was 10, 12 years ago. No, this was longer now. This was 20 years ago. So we knew this, and now you can imagine these numbers have doubled, more than doubled, because of the transition from this was opiate medications versus the fentanyl today. But insufficient evidence that counseling alone is effective is true. Medications that are essential for opiate use, and we're going to talk about these three: methadone, buprenorphine or naloxone, which is Suboxone, and extended release naltrexone or Vivitrol. Okay. Now, this was interesting too. Like, people want to argue, not argue, I'll say discussions. People want to have discussions about MAT and substitution all the time. And it is staggering the amount of evidence that comes in every day. Like, this is April 2022. Veterans who take medication for opioid disorder for at least 15 days have more than a 50% decreased risk of dying by suicide compared with those who do not. I mean, 66, buprenorphine in particular was associated with 66% reduced risk of suicide compared to none. That's staggering. I mean, those are big numbers, and you're talking a life or death situation. So the point of that is that we know that it's a medication first mentality and treatment for opiate use. Otherwise, we don't make it. And I was talking to Jamie too, that the newest studies coming out, the one lady on one of the documentaries, she's a Boston mass addiction doc. She basically put on record and said, without these medications, there's a 0% chance of success in 1 year. The studies show it's less than 5%. So you got to use medications. Now, this is a busy slide. We'll get into the details, and there's basically three options, okay? Now, FDA-approved medications, receptor, I'm going to get into a pharmacology lesson, but agonist means an activator. Antagonist means a blocker to antagonize, and then there's a partial agonist, means partial activator. There's methadone, naltrexone, buprenorphine, naloxone, which is Suboxone. Narcan, as we know, is the reversal agent. And then this one got FDA approved called lofexidine, which is basically a clonidine, which is an alpha-2 blocker, which helps reduce withdrawal symptoms without substitution. When I went through withdrawal 20 years ago, we didn't have these meds. We use clonidine, which is an alpha-2 blocker, which just kind of settles down the sympathetic fight or flight response the body goes through with withdrawal, and it can help. I still use clonidine because it's essentially the same and much cheaper. But we'll talk about the differences here. Now, if anybody needs a visual on that, an agonist is an activator. That's methadone. The more you take, the more activation you get of the opiate receptor. Naloxone, Vivitrol, or naltrexone is a full blocker, meaning it blocks the receptor and has no opiate effect whatsoever. Buprenorphine, which is what is in Suboxone, is a genetically designed drug that's brilliant in the fact that it's a partial agonist, meaning it's dose dependent. And a lot of medications these days, a few newer medications are dose dependent, meaning at lower doses, it activates the opiate receptor, meaning it alleviates withdrawal, cravings, and detox. But at higher doses, it actually blocks the receptor. So it has a ceiling effect. So it's very difficult to overdose on, and it blunts the other opiates from working. So it's a win-win. Okay. Now methadone. Methadone is, somebody asks, is methadone the same? Methadone is not the same. Methadone was designed many, many years ago. These are the old methadone clinics. This is how we first started treating heroin addiction back decades ago. Methadone is a synthetically designed agonist, full-blown substitution therapy, must be administered through regulated opiate treatment programs. The most common ones in town, I don't know where everybody's at. Behavioral health group here in Kansas City. They have multiple groups that we work with. I worked at University of Kansas Methadone Clinic. There's a Center for Change in Lawrence that we know. Topeka has several. Wichita has several. Now, these started as federally regulated clinics where people would go and get dosed with 30 milligrams of methadone their first day, and they have to show up every day, 6 days a week, to be monitored, and they adjust the dose slowly accordingly and watch them for withdrawal symptoms, and they try to stabilize a dose where they stay on that medication and hopefully they don't relapse, right? And then they stay on it as long as they need. Now, you have to go to a treatment program to do these things. You can't do it in outpatient. You legally can't do it here. I can detox people off it. I can taper people off it. I can initiate high risk patients like pregnancy, but mostly it has to be through a federally regulated treatment program. I don't mind that because there's some high risk patients that I like to show. I like to be seen in person 6 days a week with the counselor. So I think there's a benefit there. And also with that buprenorphine, it has a ceiling effect, as you saw. There's only so much pain relief that buprenorphine can provide. So I had 2 patients here that in the last month that I just wasn't able to manage their chronic pain with buprenorphine because they've been taking such high dose opiates that they'll have to go to a methadone clinic to treat both their opiate addiction plus their pain. Okay. Now, heroin use, you can see, we know that the standard dose is about 60 milligrams, which is effective. 30 milligrams initiates and it saturates the receptors. That's what we use to start. Now, relapsed IV drug use, people talk about getting people off these medications and substitution as much as possible. We can see by this diagram back in 1991, and it holds true today. You can see as people came off the treatment since stopping, by the end of 12 months, 80% had relapsed. So we have to stop putting people into this box of saying this is a certain amount of time that you have to stay on these meds. We have to start looking at substitution like other chronic conditions. People ask me, well, you're substituting one for another. And I was talking to Jamie as well. I said, yes, I don't argue that point. I say you absolutely, yes, we are. Just like diabetes is for insulin, just like steroids, just like Synthroid is for thyroid, we use substitution all the time for medical chronic conditions, and we need to do the same with opiate addiction. That is the point. And so when people argue about that, instead of going against it, I say, you're right, because it is effective. Same with methadone. We can know why. I used to go back with Dr. McNally when he was alive at KU. He used to fight the TV, the news stations who were against methadone clinics and the criminal activity. The bottom line is harm reduction works. And a lot of studies are done in methadone clinics because of engagement. People show up, but we reduce the spread of HIV, clean needles, fentanyl strips, reduction of criminal activity, drug use. Absolutely, absolutely essential. And harm reduction is the gold standard, and we need to keep doing it. Buprenorphine, we talked about this is a partial agonist. Like I said, at lower doses, it hits the receptor. At higher doses, it blocks it. I would say the usual dose I try to get people on, it's about 8 milligrams a day. We will detox and use higher doses at first, and then we use lower doses later because the brain and the body will heal from opiate withdrawal on its own. So hopefully they need less. If there's the one thing you may hear from people when they talk about buprenorphine or Suboxone, if they take it on the street or they take it in, they'll say they're allergic or they had a bad reaction. What you have to be careful about with this medication is if you take it too early, after you took fentanyl or any opiate, you will precipitate withdrawal, meaning it'll go in and clean out the receptor and make them have withdrawal. So we have to wait in here. Like I always tell them, you want to wait at least 12 hours. And I always tell them, like, you want to wait till you're feeling pretty crappy to take your first strip or tablet, because then it'll start working. It'll give you activations rather than give you withdrawal. And it's not going to hurt them. It's just uncomfortable. So if you precipitate opiate withdrawal, people talk about it. I've done it several times in here. People want to get aggressive and start early. They manage. We give them other medications and hang out a few hours and get through it. We used to use 32 milligrams. Go ahead.
A quick question. So they just want to make sure they got this right. So antagonist blocks, agonist is an activator.
Right. Antagonist. Where is that? Basically, yes. Antagonist, yeah, it looks like you antagonize something negative. It's the blocker, and agonist is a full activator. Does that make sense? I always say activator and blocker just to make it easy for people. So, yeah. Now, we used to use higher doses back then. This is just kind of the brain scans of buprenorphine. The one thing I do see that is a common mistake with prescribers in the community is we just prescribe too much. That's part of the problem with outpatient monitoring is people very rarely need 16 milligrams. And if you do, 93% of the receptors are saturated. So we used to use up to 24 and 32. People just divert and they'll tell me that. Very rarely do you need that much, but you start low and you titrate up to a dose that at the end of withdrawal, you're just trying to manage their cravings. You got to remember what the substitution, like people, what I'm trying to emphasize is when people are misusing fentanyl, in particular opiates, they're bolus dosing themselves, meaning they're going up and down to intoxication, euphoria, to severe withdrawal. And the brain, the body's up and down, up and down. What buprenorphine and substitution does is just give a low, steady state that allows the brain and the body to heal back to that low baseline state. And there is no euphoria with buprenorphine. There is no high. If you gave it to someone who's naive, who've never taken an opiate, and you give them buprenorphine, they're going to get a buzz. There's no doubt. But for these opiate dependent patients, these medications, there is no euphoric effect. It simply just saturates the receptor enough that their irritability, their cravings, and so forth are subsided. And that's the goal. And I always tell people, look, we want to get you on less and less because that medication lasts a day and a half per strip. In the UK and Europe, they will use it every other day. In this country, we prescribe too much too often, I believe, to where what the individual doesn't realize is that for the next 5 to 7 days, that's the dose in their system continues to go up based on their half-lives, and they'll often get sedate. So anybody who I manage with Suboxone, I always tell them, you're either going to go to rehab or you're going to go to my outpatient if you can, because I want to watch how you do walking out of here for a week, and almost inevitably they will get tired because there's too much in their system. So they can use less and less as they go. And sometimes we get them down just to 2 milligrams once or twice a day, and it works really well. Now,
So
here's
quick question.
Sure.
So Danielle's wondering, so is it correct in saying that most MAT treatment should last 6 months? Do we know how long insurance covers this type of treatment?
Well, we know that the newer information that we're gathering is we know it should at a minimum be 6 months, a minimum. Okay. When I went to the AAAP years ago, we used to taper people off in a matter of weeks, and then it was 2 months, and then it was 6 months. And finally, we got smart enough to say, you know what, there is no timeline, because the sooner we're ripping people off, the worse that they do. We do found in the newest studies that anything 6 is absolutely detrimental. Insurance will cover. Buprenorphine and Suboxone is now generic. Vivitrol is expensive, but there's ways to get that, or the naltrexone tablet is generic, and methadone you can stay on as long as you can. Now, this study emphasizes exactly what we were just talking about. This study early on took all these 653 opiate patients, 2-week stabilization, 2 weeks, they put them on Suboxone, they got them well, right? At 2 weeks, at 8-week follow-up, 6.6% had success, meaning essentially 95%, 94% relapsed after a 2-week taper. They put those people back on the Suboxone for 12 weeks, right? That's 3 months, right? Then they took them off again after 3 months. The success rate was only 8.6%, meaning 92% relapsed again. So if that makes sense, if you look at brief phase, only 6.6% success rate, after taper, after 3 months, only 8.6. Those are dismal numbers. And when they're on, basically what we found out is it's emphasizing without these medications, our success rates are single digits, if not 0. When they're on Suboxone or these medications, our success rates are about 50 to 55%. which is a big jump, right? That's half the people versus 90%. So that's the reason that we're extending these tapers. And this is again why we're collecting the data, because we really don't know. And every individual is different. I've had people on this medication for 8 years, and they just do well with 2 milligrams once during the day or twice a day. And every time they try to come off of it, we have trouble. So I hope that kind of answers the question. So this is kind of basically showing, look, the quicker we've taken people off meds, the worse they do. Acute withdrawal is what we focus on, like in my hospital, the acute withdrawal symptoms from like alcohol, benzos, opiates. That's a severe sickness. But you have to remember or try to realize the brain and the body take months, weeks and months to heal. Like it doesn't just heal in 5 days of detox. You know, it doesn't matter if it's alcohol, opiates, or any other substance. If you remember how the brain, the body continually monitors itself, regulates itself constantly, just like your temperature. We substitute with medications early because people can't physically even function. That's the first part of treatment, because if you have to wake up every day and use, you're not using to get high anymore. You're just using to maintain, to get out of bed, to maybe even get out of your chair to go to work. You're just maintenance using, drinking throughout the day, using fentanyl throughout the day, especially fentanyl. These people are using multiple times a day just to maintain, to stop puking on themselves. There is no euphoria anymore. So when you get to that phase, we get these meds in, we get them through the first week. That's just the first part. You have to get the physical withdrawal dependency out of the way first. Otherwise, nobody can get on to the next step, which is actual treatment, groups, education, therapy, all the healthy activities, diet, back to work, social connections, spirituality. So you have to get that part first, but the brain and the body take weeks, if not months, to recoup from all that damage and all those fluctuations in their substances. And it's called protracted withdrawal syndrome. And so those can take for a long, long, long time. And I always tell people, I'm like, look, now you're not having stomach issues, you're not throwing up, you're out of bed, the pain's bad. Now we got to do the real work. But it does take a long time for the brain and the body to function.
So then the question, sorry,
Yeah.
one other question. So does the brain and body eventually completely heal?
Yes, but it takes much longer than anticipated. Like even with methamphetamine use, we do the brain scans. It takes 11 months in the brain scans to see to recoup back to its own dopamine levels. That is a very difficult substance to treat because it causes such irritability, cravings, depression, and the brain has no dopamine to your feel-good neuroreceptor. I have more people leaving against medical advice and non-compliant with treatment over stimulant use than anything else. It's probably the hardest one for me to treat because I don't have any real medications to do it. If you want to talk about off-label stuff, I crank some Provigil or maybe some bupropion or Wellbutrin that's structurally similar to amphetamine, these kind of activating antidepressants. And I could talk about that, but there's really no like benzodiazepine for alcohol withdrawal or methadone or Suboxone for opiates. Like meth, it's just kind of like, wow, you just have to symptomatically manage them. It's really hard. Even in alcoholism, they did brain scans on alcohol use disorder patients when they stopped drinking and they looked at the activation in the PET scans when they had cues of the wine bottle or whatever it was in front of them. That brain actively was the same. You couldn't tell they were even after 6 months of no drinks, the complete absence, that brain still fired away as if it was actively drinking even at 6 months. But at the end of it seems to be about a year that we see it's not that small changes don't occur, but physically we see structurally the changes in the brain after about a year. And this is a behavioral problem, right? Like you have to rewire that brain, just like if you lost function in a limb. It's a behavioral issue where instead of going left, you got to go right. Instead of up, you got to go down. You have to train yourself to do different things, react different way in a different habits to where the brain, but yes, to answer the question, yes, the brain can eventually completely heal. Now there's some substances aside like inhalants and stuff that cause permanent damage that I'm not going to talk about, but there is some others out there. And these synthetic designer drugs, I can't speak to because we don't know. Now, naltrexone, Vivitrol, we talked about. Now, this is like the holy grail of opiates, right? Now, this is the full blocker, and it makes sense. Now, most people who come in are feeling so physically bad that they need substitution up front. They need methadone, they need Suboxone, they need opiate just to function, to feel better. Ideally, now I say, how long should you stay on these medications? I have people who I use Suboxone to detox with, and they don't want to stay on it. And I say, that's okay. Over the next week, we're going to watch you in rehab or an outpatient, and we'll wash you out of everything for a week, and we'll get you to naltrexone or Vivitrol. I don't care which one it is, as long as they're on one of them, but you have to wash out of all opiates, including Suboxone, for 1 week before you can get on the full blocker. And and we do it all the time. Now, that's the oral naltrexone versus the Vivitrol. We don't talk about that. The abstinence, the cravings is significantly reduced in naltrexone and Vivitrol, just like Suboxone. The treatments are huge. I mean, it's 90% versus 30%. I won't get into the details of the slide. We're giving naltrexone and Vivitrol to prisoner release coming out of jail, or having much greater success rates, obviously. And I applaud states for doing that, because I always tell these individuals, like, I got a bunch of Cavalier Cowboys sometimes, like, I don't need anything. And I'm like, why don't you just put something in your system that in case you get an impulsive moment or you're around the wrong situation, that you know that you can't react to it anyway, so there's no reason to do it. Now, the question is Suboxone versus naltrexone versus methadone. Now, the study, this was the first head-to-head study, and essentially you have to break down the numbers. Relapse 57 versus 65 is relatively similar, right? The bull blocker versus the partial activator. Now, opiate-free weeks was much higher with Suboxone than Vivitrol. So people will say buprenorphine is agonist therapy or activating therapy works better. Here's the caveat. A majority, almost all the relapses with the shot occurred in the first week when they were detoxing. So it seems that if we get people detox first and get them feeling physically better, and they get to the Vivitrol and naltrexone, they do just as well as the buprenorphine. That's the caveat. And so when people go to Vivitrol, when they come into treatment, some people come in and say, I don't want Suboxone, I don't want an opiate, I want no substitution. You can imagine it's harder for them to stay sober during that first week. But once they get there, they do okay. So I'm a big proponent of it. They have extended release tablets for buprenorphine now that last up to 6 months. Sublocade is a new monthly injection that's expensive, and trying to get it approved. Truman's doing it with Dr. Burgess and some others. I'd like to see that. This is a monthly injection, which is great. Why is this great? Because we don't have to rely on the patient to take it, but you know where it's really great? Sober living, nursing homes, like jail, like the places where people are not allowed to take Suboxone. Well, if you get the injection, it's already in there. So I think it's fantastic, and it works really well. I got one person in here now just got a Sublocade injection. So anything that improves compliance, we'll do it, and it actually works. And then we can finish up with Narcan. You guys know what Narcan is. It's the reversal agent. It has no abuse potential. It's life-saving. It's kind of becoming more and more topic now, because we're having to use more Narcan than the usual doses because of these high-potency fentanyls. So we're having to use multiple doses. So now they're coming out with double strengths, but don't get tricked. I shouldn't say trick, but I'm already getting calls from pharmaceutical companies with brand new injectors and super Narcans because of the 8 milligrams, and they want to charge you a fortune. This is the Narcan kit. Most people don't use an injection that you can get. They pulled this off the market. I think maybe you've seen me talk about this before. This got on 60 Minutes because it was so crooked. I gave these out at the VA because the government, I won't be critical, at least bought them. But this little injectable auto injector was over $3,000 a piece. And so, and it cost $1.50 for a shot of Narcan. It was $3,000. So that company got put on 60 Minutes and got criticized for that. And then they got accused of all kinds of wrongdoing, and that company is no longer there, and that product is no longer on the market. They did approve this nasal spray. If you guys have not seen that, that's most commonly what people will use. Everybody who walks out of my hospital or under my care gets a nasal spray. It's over. We have standing orders in our state now. Before, when I started doing this, it was really hard to get people Narcan. Now pharmacists can give it without a prescription, and usually if they get a Suboxone script, they will just give Narcan to it, because we need to get as much Narcan on the street as we can, because you never know when you're going to approach somebody or somebody's going to overdose, and you always have to assume it's Narcan, and if it's not going to hurt anything. Okay. Again, we know it works. We're not doing enough of it. Most treatment centers are not utilizing these medications. It's gotten much better, but it's still less than about 15 to 20% in this country are actually receiving medication-assisted therapies. It's gone up, thankfully, over the last 3 years or last 5 years that you can see, trying to get prescribers to prescribe these medications, clinics, and so forth. but we got to keep doing a lot more, and that's part of this talk. So I'm going to stop there and just, I guess I rambled just fine for 2 hours. Sorry about that. But if anybody has questions or where do you want to go from here is fine with me.
So there was a nice discussion that was kind of happening through the chat, talking about, in particular, the availability or being able to use MAT, so medications for addiction treatment, while in sober living, and that just kind of the stigma that is happening even within treatment and recovery when it comes to MAT. And so just wanted to get your viewpoint. There's a lot of discussion about like, what can we do about this?
I will tell you, yes, I will. I'm very opinionated, as you can tell, on these things being recovered, but it angers me, and we're making some progress. Like it's steps, not jumps, people. But I will tell you, as it comes to MAT and the stigma, with the sober living environment, that's why the Subocaine is so helpful with those type of situations. When 3 years ago, we couldn't get anybody into a sober living with Suboxone. I understand why they do that, because they do not want to put the other individuals at the home in risk. Because if somebody doesn't use an opiate, they could get a buzz off buprenorphine, any controlled substances, it was black or white. There are now several that do allow Suboxone, and there's more and more every day. So I will tell you, there are options out there, and the sober and recovery houses that we work with in Kansas City are now allowing people to do Suboxone. So that's good. So it's not an absolute black or white. The Oxford houses in themselves, we're finding is you have to talk to each one individually on what their philosophy is. But we have found Oxford homes now that allow Suboxone. Other controlled substances, they're still negative on, but most of them now actually are allowing the Suboxone, which is good. Now, the stigma within even recovery groups like AA, NA, and so forth is still there. This is my saying, what I tell everybody on that. I just had an individual in here. I have almost lost individuals, and when I mean lost, I mean almost died, due to an opinion of somebody in their group telling them they weren't actually in sobriety because of the medications they were taking or the psychiatric medications they were taking. I always tell people, what you take is between you, your doctor, and your higher power, and nobody else. And that's where I tell them to leave it at, because unfortunately you're going to get a stigma and an opinion if you bring up MAT, even in AA, and you're on antabuse, or Campril, any of them. They'll try to tell you, some people will try to tell you you're not really sober. NA is a big one with substitution. And I argue that point because it's like, well, you're not really in recovery. Yes, you are in recovery. I don't care what medication you're on. If it's a strip under your tongue and you have your life back and you're full functioning member of society, you know what? Yeah, you're absolutely in recovery. So there is a stigma out there. There are some treatment programs that are, I'll put it this way. You watched it even with two of the biggest in the country, with Betty Ford and Hazleton merging forces 10 years ago. There was a huge cultural shift up there because they were fully 12-step faith-based with no MAT. They had to clean out 60% of their administration and staff because they either had to get on board with MAT or they were out. The federal government came in and said, you're either going to offer MAT or we're not going to provide federal funding for the addiction treatment centers in the country. So unfortunately, there is a stigma there, but all we can do is keep talking about what the data is and what they show. I get family members all the time that talk to me and say, I don't want my son or daughter or anybody on these things. And I say, I understand that. I give them my spiel and I talk to them and I go, I'm not treating them as a statistic, but here's what I'm going to tell you what they are and your chances of success are. And after I explain to them how things work, they usually buy into it.
And that kind of goes along with another question that somebody had earlier that said that we tend to have patients that will not want any medications due to worrying about becoming addicted to another drug. And then, some are worried about methadone, some are worried about Suboxone, that it's just a replacement. And so what do you recommend for these patients?
I have my same talk with them because it's a conversation they deserve to have and you should have. And I explain it to them in terms of triage and harm reduction. I tell them, I'm like, look, you're coming in here withdrawing off of fentanyl and you had an overdose 3 in the last month, or you're feeling this physically sick. We'll worry about getting off the medication after. Let's get you stabilized first, because versus coming off something like fentanyl or the opiates and heroin off the street. If I can get you on number one, you're opiate depleted to begin with. You need substitution just for you to physically function right now. So many of these people are out on the street trying to detox on their own, which doesn't work, using fentanyl and other substances. I tell them, well, let's get these medications on board and at least get you stable. If you don't want to stay on them, let's talk about getting you off of them. Now, are they habit forming, dependent forming? Yes. But you're already on something that's habit forming and dependent forming, of which you're so physically ill, you're in a hospital. At least if you get you on these medications, you're in a monitored, managed setting that I can slowly taper you off these things if you wish. And I always tell them that's a nice thing about Vivitrol naltrexone. I say we are substituting it because we need to right now. If you don't want to, I always tell a person, look, we can just use these as a detox Band-Aid if you want and get you through the next 3-4 days. And then we can work on getting you to Vivitrol naltrexone. But yes, you have to have those conversations. I get people all the time who say, I don't want to take that medication. I don't want to be dependent on something. I have to kind of poke holes in their theory because I'm like, well, wait a minute. You're smoking an ounce a week. You're drinking a fifth of Jack, and you're dependent using all these other things and these designer drugs instead of using something that we know that is FDA approved or beneficial or managed by a provider in a safe setting. So you kind of have to challenge them a little bit on it, but also be sensitive to, like, I'm not here to get you addicted to something else. I'm here to get you off what is going to kill you. And the methadone, Suboxone to get off of, people talk about how difficult it can be but it's also impossible. It's also very difficult for them to get off opiates in the first place, because what we find is it's not hard getting from 80 to 120 milligrams down to 30 of methadone, or even 16 or whatever it is down to 2 of Suboxone. It seems very difficult for people to get off that very last little bit that's just enough to saturate the receptor to keep the irritability and cravings at bay. But they're already dependent on something. I always say, look, we're just going to substitute this for now, and then we'll slowly taper you off of it. And usually they will buy into that.
So really quick, because we've had a couple of questions, and I want to make a quick little shout out. So one of the things that we have done, and Dr. Willey's been part of this as well, is we have started a coalition here in Johnson County called Johnson County Prevention and Recovery Coalition that is focusing on, currently right now, we're going to be focusing on opioid and fentanyl prevention, harm reduction, treatment, and recovery. But we are also probably going to be focusing some, maybe even on poly drug use, as the data is kind of showing that. So we meet on the third Thursday of every month from 3 to 4:30 over Zoom. If you are interested in it, let me know, and I can get you information. So, and Rachel, if you want to put, I don't know if you can, but put the link to register for our Zoom meeting for our coalition. We have just gotten started, like we just started in April. So if you are interested in that, you are welcome to be part of the community-wide effort to focus on again, prevention, harm reduction, treatment, and recovery. And so we did have a question from Susan, who's a school nurse, and so she was asking, hold on, I got to get to it. She said, we have several Olathe school nurses here today. What part can we play in prevention? Are there any educational programs for middle school or high school students? And then she said they have had to administer Narcan for overdose, and she knows that all the other high school nurses have Narcan, or have had to use Narcan at least once, if not more.
I don't know, Jamie, that's as much a question for, I think, you as me, as myself, like in terms of the coalition, that's a good question. If we're not doing Narcan education and training for people, we should probably be getting that on board, especially with the schools, because the ages are getting younger and younger. And then in terms of the education piece of it, the honest answer for me is I always admit when I don't know something, I don't know. I'm buried here at the hospital, and that's where I kind of live. But are there efforts out there, Jamie, to do that with this coalition? I know you're working with ACT, KU, and everybody else.
Yes, so there's a couple different programs. So one is there's a prevention program through DEA, and they're focused actually very much in the Kansas City Metro, including Johnson County, because of we're a high drug trafficking area here. And then there's also another program through KDADS, I believe, as well. And Michelle Reese, you probably could speak more to that as well. So there's a few different, and Rachel just put in the information about the coalition. And yes, you are more than welcome. Anybody is welcome to come. Here is just another one. So registering for the coalition meeting, and anybody's welcome to attend that as well. But yes, that is actually something, Dr. Willey, that we are going to for sure be looking at is that prevention aspect. One other thing, so there is the Kansas Opioid and Stimulant Conference that will be occurring on November 10th. Registration opens in September. I know that they are still looking for presentations as well, and that conference is going to be happening in Topeka. So, and I've been to it. It's fantastic. So that is also just another resource that's available. Okay, any other questions? Okay. Well, thank you so much, Dr. Willey. Thank you for answering all the questions as they came in. We really appreciate it. We're getting a lot of thank yous. Just very appreciative of the training, very insightful. And I know I always learn so very much from you. So thank you so incredibly much. And for agreeing to do the presentation, for agreeing to pivot to virtual. We really appreciate it.
Thank you. Thank you for having me. Make sure the slides are available. If people give my information, if they need questions, to get a hold of me. Yeah, I appreciate everybody for attending. Hope you learned something. I hope it wasn't too long and boring of 2 hours. So I appreciate it very much. And I'll see you soon, I'm sure, Jamie.
Yes.
All right. Thank you, everybody.
Okay, thank you, everyone.
Bye.
Bye.
There's a question in the comments. How do we get CEU?
I will be sending a certificate of attendance with contact hours along with the slides later today.